Well, thanks very much for having me. It's a pleasure to be here, and I really want to thank the previous speakers throughout the day. It's been enormously educational for me. I've really enjoyed this so far, so thanks very much for having me. I was asked to also talk about incorporating advanced structure and function testing in glaucoma, and to talk about kind of, what clinic is like in this regard these days. I'm going to talk about a clinical trial implant that's not yet approved, no relevant financial disclosure related to that. And I am a paid consultant advisor for Zeiss. Everything else I'm going to talk about today, though, is funded by grant support from these foundations and sources. So first of all, I was asked to just talk briefly about glaucoma care in the time of COVID. For us locally, elective procedures and all the associated clinical activity reopened May 4th in the Bay Area. And of course, these days, all of our patients and staff get masked and screened and checked for fever, and all of our surgical patients get swabbed for testing preoperatively. I think a lot of the same approaches that are being taken throughout academic and private institutions, both in the United States and around the world. We've worked hard to try to look for additional opportunities to innovate in this period. There was a national backlog for slit lamp shields, and so we had to reach for some homemade innovations there. That's a picture of me picking up some acrylic shields at Home Depot, and Artist Montague, one of our faculty, and her daughter cutting the shields to fit onto our slit lamps in the clinic. So that ended up being a quick and ready alternative for us. We've also been innovating with some drive-through vision and eye pressure checks. That's obviously been really helpful to us on the glaucoma service to be able to offer this to patients. It's obviously a very low-risk opportunity to get some key pieces of data that we can then follow up, especially in the subset of patients who are really scared to come in. This way they don't leave their car, they actually just roll down their window for about 15 seconds, and we can get that data and then follow up with them by phone or by video visit. Our ambulatory clinics have been resuming. You can see the dip right here in ophthalmology clinic visits. This is on the adult side. Pediatrics has looked very similar. So for about the last 6 weeks, we've been back to kind of our pre-COVID levels. And a similar picture when you look across all of the ambulatory clinics. One big difference, though, of course, is that in ophthalmology, we're just not that effective in using video visits. I keep joking to our administration and patients that no matter how close they lean into the webcam, we just can't see inside their eye. So we're running about 1% to 2% video visits now. Other unmet needs have really been amplified here in this time of the pandemic, including the need for home visual field testing and also frequent visual field testing. So really beautiful paper addressing this. We know that testing peripheral vision 1 to 2 times per year in the office really delays diagnosing progression, and this was captured in a recent paper modeling this point, looking at home monitoring to allow earlier detection, and such that the visual field progression that you could detect in 2.5 years, testing twice a year in clinic, you can test that by weekly home monitoring of visual field testing in less than a year. And that assumes, poor data input, low compliance, et cetera. So still some big unmet needs that I think the COVID era is going to help us usher forward. In terms of advances in visual field testing, this has been really a big change for me over the last couple of years. Talking about Zeiss's HFA3, for example, which is our main clinical visual field test at the Byers Eye Institute at Stanford. A couple of advances worth really talking about. One is the CETA faster, and again, thinking about wanting to get our patients through clinic as quickly as possible and minimize kind of either infectious risk or, patient fear of infectious risk. And so some advances there that have helped. And then I think clinically a really important advance has been the CETA 24-2C. And this is like a 24-2, except it adds an extra 10 points in the central field. And that mimics or correlates with a patient's performance on a 10-2 visual field. And I think there's been a real appreciation over recent years. A couple of really beautiful papers over the recent years from Don Hood and collaborators. Here are two examples from their group, capturing the fact that glaucoma damage in the macula is common and can occur early in the disease. So early detection, that's certainly a key element that we don't want to miss on a standard 24-2. And also our ability to track later in the disease could be aided by this. So really important advances there. Also, our advances in the ability to analyze these Humphrey visual field tests using the Forum Glaucoma Workplace, which I find myself on obviously in every clinic now. The reliability index can be aided here as well. If you're interested in one or a few points potentially getting worse, you can just double check, for example, using this rely function, which actually takes a little infrared snapshot of the eye while that point in space is being tested, and then saves that data. And so you can click on a point in space maybe that you're interested in whether it's getting worse, and just double check. You know, here's an example wherein 2 of the 3 times this eye was tested at this particular point in the visual field, 2 of the 3 times the eye was closed actually. So some really nice advances there in how we look at that. The guided progression analysis, this is obviously key. I mainly look at the GPA, rarely look at just you know, other details from the field that's not visible on the GPA, because getting a sense of the recent progression, as well as, you know, looking at that slope compared to the patient's age and estimating what their future might hold. Obviously, we're really focused on tailoring glaucoma treatment to the individual patient and their prognosis these days. So really important to be doing that. Advances in the OCT side, I would say the main thing that I've been availing myself of is looking at the macular ganglion cell complex in addition to the nerve fiber layer. And again, a series of papers have really captured the importance of doing this for 2 reasons. One is that early in disease, it may pick up on some structure or structure function correlations that tip you off to the presence of early disease. And then later in disease, after the nerve fiber layer hits an apparent floor, the macular ganglion cell complex can continue to show progression. Working within the glaucoma workplace on Forum, I think there are a number of different newer printouts that I find also very useful to you know, just kind of guide my typical clinic day. One is just bringing structure and function together and being able to see the visual field, the nerve fiber layer, and the macular OCT ganglion cell complex, all in one printout by eye. I find this enormously useful in clinic for quickly assessing structure function correlation. Here, just for an example, on the right eye, this inferior arcuate with a significant nasal step, which, you know, the nerve fiber layer, we've got both some inferior and some superior thinning demonstrated, but much more macular thinning on the ganglion cell complex, superiorly correlating to that inferior field defect. So very helpful to look at it that way. So let's just give a couple of case examples here. One is, you know, the usual question, is this person getting worse with their glaucoma? This is a lovely lady that I've been following her visual field over 4 years, and she's on maximally tolerated medical therapy, and the question is whether she's been progressing. And here, looking at her guided progression analysis, you do get the sense that maybe there is this downward slope here over time. Here again is a really nice way to look at that, visualizing her structure and function together over time. Again, the more severe defect in her superior field, captured in this inferior thinning of her ganglion cell complex. But, you know, we've also got this question in the right eye. You know, we can see this parafoveal arcuate scotoma here that may be represented by some of the change shown in the superior retina just above the fovea. So if we zoom in and use Glaucoma Workplace, we can put the structure function indices that we're most interested in together and look at them together on this GPA. you can appreciate a few things. One is, you do want to hone in and watch out for single exam points that may be sort of, a bad day. Here I've chosen to plot the mean deviation, the visual field index, and then both the RNFL and the ganglion cell layer. And, although it's not that compelling and it looks like she was doing a little better on her fields, then a little worse on her fields, being able to see this recent worsening in a couple of fields and put that together with the ganglion cell layer thickness from the macula, also showing thinning, that really helps solidify, the feeling that this is a patient who, is showing some structure function progression in her macula. And in fact, when we zero in on this, you can see this progression in this inferior, this appearance of this parafoveal inferior defect. And again, like it looks like she also has a concomitant worsening of her ganglion cell complex in the matched superior field. So it really suggests that there's progression at or near fixation. She's on maximal therapy, and what otherwise might be kind of incidentally overlooked or missed, it really brings it together to say that this is a patient who probably does need to advance to surgery in her case. Let's take another case. This is a 92-year-old man with pseudoexfoliative glaucoma. You can see his right eye is in good shape, but his left eye has some significant inferior and superior field defects. And there's definitely this sense when you look over time that there is this progression over time. And we've been following for quite some time and have a lot of this field-based evidence for his progression. And again, for a patient on maximum medical therapy, might be really inclined to think that this is a patient who also needs to go on to surgery. Using the guided progression analysis, we can also see, this fairly significant and steep progression over these last years that we've been following. At minus 3.5 points on the visual field index per year. But this is where the digging in and using the glaucoma workplace is really helpful. 2 years ago, we added a topical therapy and successfully decreased his eye pressure to a new target pressure. And so when we actually reset his baseline to that time point and look just at the most recent 6 fields here over the last 2 years, we see that actually it's considerably more stabilized, probably a little bit of progression, but not the very significant progression that was suggested looking back over time. And so I think that's a really great case example of where you want to customize within the glaucoma workplace to that particular patient's clinical course. And then I'll just give a third case. This is obviously an area near and dear to my heart, as we're doing a lot of clinical trials now in neuroprotection and more on the way in glaucoma. New set of therapeutic candidates that are moving into this field that really can promote neuroprotection, which is to slow the decline or flatten the curve. In glaucoma, we were trying to flatten the curve before the pandemic. Or even give neuroenhancement, which would be like giving a booster shot to the sick retinal ganglion cells and improving their structure and or ideally function, obviously. So we completed a few years ago a phase 1 trial for CNTF, ciliary neurotrophic factor in glaucoma. This is inserted through Neurotech's Renexus NT501 implant, which is in clinical trials right now in phase 2 for glaucoma, I'll come to, and in phase 3 for macular telangiectasia neuroprotection. The first trial, no serious adverse events, no effect on intraocular pressure. It's inserted very quickly through the pars plana as shown in that last video. We're now, as I mentioned, in a phase 2 randomized controlled trial. It's a 3-center trial at Stanford, Columbia, and Glaucoma Associates of Dallas. And then NYU has actually been taking on a significant line share of the data analysis as well. Patients are randomized in this trial 1-to-1 in the implant versus sham surgery, no implant, although they could then cross over into the implant side. And again, this is funded from foundation work, Bright Focus in particular, as well as some philanthropy. So here's a patient, and I'll just bring up this question, is there any evidence for improvement in this clinical trial? Here's a patient, and again, using glaucoma workplace, we can put together in the right eye here the visual field index, the nerve fiber layer thickness over time, and the ganglion cell layer thickness over time. And, you know, little hard to say here, maybe some progression in the visual field when looking at the index over time. You do get this hint of retinal thickening captured in both the nerve fiber layer and the ganglion cell thickness. But then important to note again that this is a patient whose clinical trial implant happened over here just about 2 years ago. And so there, when we reset the baseline to their immediate pre-implant baseline, you know, that kind of changes again our assessment here, where we get a very consistent picture, it looks like, of visual field, at least stabilization, maybe improvement, and certainly this thickening on both the superior, more than inferior nerve fiber layer and possibly macular, not shown here. So in summary, I would just say that the clinical decision-making is really being greatly aided by two important elements. One is the advanced measures of visual function by visual field testing and advanced measures of retinal and optic nerve head structure by OCT. And there I would highlight the importance of probing the perifoveal or more central macula with both the visual field and the macular OCT testing. And then also a second really important point are the useful views and analyses that we're getting of the structure function correlations in progression and how that can really change our ability to make, you know, intelligent decisions for our patients in terms of recommending surgery or recommending holding off. So with that, thanks very much for your attention, and I'll be happy to take any questions as part of the upcoming panel. So thanks very much.